Good morning, good afternoon, good evening. My name is Rajanathan. I'm the Executive Director of the Alliance for Health Policy and Systems Research, and it's my great pleasure to welcome you to today's webinar entitled Aiming for Impact, Embodying Health Policy and Systems Research to Advance Country Priorities. And over the next hour and a half, we have a great set of speakers to reflect on this issue about, in particular, how can health policy and systems research be more useful to countries and have impact in improving service delivery, policy development, and health outcomes. And also, as part of today, it is our pleasure to launch the new strategy of the Alliance, Aiming for Impact, which is our new strategy for the next 5 years, 2024 to 2028. I'd like to thank our speakers, but I'd also like to thank many of you who've engaged with us over the last just over a year as we've developed the strategy. We've had hundreds of people to contribute. We've had meetings, I think, in 5 continents on the sidelines of other activities that we've been doing. And it's been a very rich process. Like always, the process of strategy development is often more important than the final document. And it's really helped us to think, to reflect on how can the Alliance best serve its mission? What should its mission be? What have we achieved and what should we do differently? And of course, the Alliance's achievements are not the achievements of a relatively small secretariat in Geneva, but of the community of people invested in health policy and systems research, invested in as policymakers, as researchers, as practitioners, as implementers, as health workers, as communities, and as individuals. And so we are delighted to have a stellar cast to join with us today to reflect on this topic and to accompany the launch of our strategy. We have the Right Honourable Helen Clark, the former Prime Minister of New Zealand. We have Dr. Jeremy Farrar, the Chief Scientist of the World Health Organization and the representative of the World Health Organization on the Alliance board. We have Dr. Rajani Ved, who's currently the Director for Health at the Bill and Melinda Gates Foundation in India. We have Dr. Diah Saminarsih, who is the CEO of cisdi in Indonesia. And we also have Dr. Cloete, who is the head of the Western Cape Provincial Department of Health and Wellness in South Africa. But thank you also to all of you. And so we will start with some messages from the chair of our board, Helen Clark, and also Jeremy, as the WHO representative and the chief scientist of WHO. Then I will present the strategy, and then we'll move to what should be a very interesting panel discussion with Keith, Diah, and Rajani. During that panel discussion, there will also be the opportunity for you to ask questions through the Q&A function. And those can be questions to the panelists, but they can also be questions about our strategy. So we look forward to those. We have a good amount of time, and so we should be able to have both a substantive and a dynamic discussion. So to start off with, I'd like to again introduce the Right Honourable Helen Clark. She's the former Prime Minister of New Zealand, the former head of the United Nations Development Programme. We're very honoured to have her as the chair of our board, and Helen still manages to do a million things. I don't think she really sleeps, and so that's just a very small summary of all the things that she's involved with. So I hand over to you, Helen, to give the opening remark.
Greetings, everyone, and thank you for joining this important event focusing on embedding health policy and systems research at the country level. This is an opportunity to hear from experts around the world on what's needed to bring about change in their countries. Also, it's a chance to hear more about the new strategy of the Alliance for Health Policy and Systems Research, which is being launched today. When I stepped into the role of chair of the board a year ago, the Alliance was marking its 25th anniversary. I've enjoyed learning more about its rich history and its innovative approaches, and also getting to know the vibrant community fostered alongside health systems global. The diversity of methods and approaches championed by the Alliance and its partners have shown the full range of what is possible. But now, 25 years on from the birth of the Alliance, it must move beyond building the field and creating a community. And that's why there's been a shift at the heart of the Alliance's new strategy towards prioritizing research and engagement activities which will have a real impact on health outcomes and service delivery. We do live in very unsettled times and face an uncertain future, but I believe engaged research can help to chart a course for health policy and systems. So the Alliance intends to deepen its engagement with country priorities and contexts, recognizing the diverse challenges and opportunities they all present. We will also build new partnerships within the global health architecture, expanding our networks and constituencies. We do want to scale up our impact on health outcomes through strategic interventions across a range of critical areas in the field. To achieve these ambitions, the Alliance needs partners. It needs you. So today is not only a chance for the Alliance to launch its new strategy, it's also an invitation to all present to co-create a healthier future. Together, we can navigate global, national, and local challenges and ensure that health policy and systems research do contribute to significant progress in reducing health inequities and achieving major global health goals. Thank you.
Thanks so much, Helen. As I said, we're extremely fortunate to have Helen as the chair of our board. We're lucky with all of our board members. And as she says, she brings a great experience on the importance of evidence and information and learning and research, but also experience on how to convert that into policy that works and makes a difference into people's lives. And that's very much the passion that she brings in terms of her role as the chair of our board. So thank you so much, Helen. It's now my pleasure to introduce Dr. Jeremy Farrar, who is, as I said, the chief scientist here at WHO, second chief scientist at WHO following Diah Saminarsih. Jeremy is literally just one of the most eminent scientists on the planet, so we're very lucky to have him at WHO. He's worked in a number of places. He spent a long time in Vietnam doing clinical research. And most recently, before his role at WHO, he was the CEO of the Wellcome Trust, which, as many of you know, is essentially the biggest research fund in the world. And so he brings enormous experience, and we're very fortunate to have him both as an individual, but also reflecting the fact that we are hosted at the World Health Organization. I'm sitting here in Geneva in the WHO building, and so we're very fortunate to benefit both from the guidance of Jeremy, but also Dr. Tedros, the Director General of WHO. So over to you, Jeremy, to also say a few opening words.
I'm really delighted to be able to join this webinar and to celebrate the launch of the Alliance's strategy for 2024 to 2028 and pay tribute to Kumanan and the whole leadership of the Alliance in producing what I think is a really inspiring strategy for the coming years. We live in a really complicated age, geopolitically, climate change, demographic shifts, pandemics, of course, emergencies, and many other great challenges. And yet we also live in what I think is truly a scientific golden age. Our challenge is not that science won't produce. I believe science is and will continue to produce. I think our bigger challenge actually is ensuring that that science is made available to the maximum number of people in the most equitable way, and it's embedded within national government structures so that good policies can be made, and then policies can be made into practice that actually improves all of our lives. And that is the sweet spot for the Alliance, and which I think is central to the Alliance's strategy for 24-28. Science on its own is of value, and we within the science team celebrate that scientific endeavor. But what we really celebrate is when we translate that science into impacting people's lives. And that's the Alliance's center of gravity, and why it's such a pleasure and honor to be at the launch of the new strategy, but also to be on the Alliance's board. Health systems, government policy systems that can absorb and make maximum use of the best science to make a difference to people's lives. To Kumanan, to the board, to everybody involved in the Alliance, all the supporters externally and internally within the World Health Organization, congratulations. And you be aware, you have the full unfettered support of everybody within the science team at WHO and within the WHO more generally. So congratulations, and I look forward to seeing the fruits of the inspiring strategy. Thank you.
Great, thanks so much, Jeremy. And we are, as you say, extremely fortunate. Well, we have the support, but we're very fortunate to have that support. And so, as Jeremy says, we sit not just in WHO, but we are hosted within the science division, which is enormously helpful, which means we sit alongside the other research partnerships such as TDR, HRP, but also with the colleagues working on research for health, on digital health, on quality norms and standards. So that is a really intellectually rich place to be, and often a lot of the work we are doing is similar. So, for example, on implementation research, and so we benefit from the ability to work together. As Jeremy says, this is very much a golden age for discovery science in health, and yet the challenges of the no-do gap, which motivated in part the creation of the Alliance 25 years ago, remain even more acute. And there's real concerns, as we've seen recently with COVID and vaccines, about the ability of our systems to scale, to deliver equitably all of these amazing new innovations and technologies. And so in that way, the task of addressing the no-do gap is even more urgent, and we should reflect on, yes, we've made progress over the last 3 decades, but there's much more to do. So thank you, Jeremy, for your leadership and your support, and the support of all of the science division in WHO. So essentially, it's a difficult task, having had those opening remarks, for me now to follow by giving you a quick tour of our new strategy. The strategy is now, as of today, is online. Those of you who registered for this symposium or didn't, you should actually have a copy. We were pleased to provide that. So please share it freely if it's of use. You can also download it by the link that's on the screen now, or by scanning that QR code. So we hope that it's of value, although, as I said, this is a product of almost 1.5 years of deliberation with hundreds of people. I'd like to thank my team and everybody who's assisted with this work. But it is an ongoing conversation, and now the much more difficult task is implementing strategy, and not just aiming for impact, but achieving more impact. So what does the strategy have in it? Essentially, when we sort of looked at the strategy, one of the things we were doing was reflecting on 25 years of the Alliance. The Alliance was first formally conceived in 1997 in Sweden at Legendal Castle, and then started in 1999 after Julio Frank, who was the Executive Director for Health Systems at the time at WHO, kindly invited the Alliance to be hosted at WHO. So very much 25 years of achievement. A lot has changed in that time. In the 1990s, we reflect, and it was driven by people like Ann Mills, Joram Thompson, Jonas Sturkey, who had identified this gap, which was also identified in the ad hoc report on health research, which WHO produced in the mid-90s, that there was a gap on health systems research, a gap on health policy research. It was still a nascent field, not so developed in most countries. And so the Alliance was created really to help fill that gap as a global institution that could support the development of the field, could support health systems research, could support health policy research, implementation research in countries, so that it could contribute to achieving health goals and improving equity. And so over the last 25 years, many good things have happened. The Alliance has contributed to the development of the field of methods, approaches, particularly on approaches such as systems thinking, health policy analysis, embedded implementation research. The Alliance has trained, provided resources, helped build a community, and our sister agency, Health Systems Global, which is the International Society of Health System Researchers, which the Alliance helped to bring into being, now says that it has members in 125 countries. So there's a strong community. There's a community that meets every 2 years in a symposium of about 2,000 people. So there is a strong community. There are people doing health systems research in most countries now. There is methods. There's an understanding of the field, of how it can be useful. The Alliance has always seen itself at the nexus or interface of evidence, research, information, data, learning, and policy, practice, and implementation, and really tried to facilitate the co-creation of knowledge between these different groups so that research and learning can actually fix problems, can lead to overcoming obstacles, can lead to improved health and health equity. So the Alliance has always convened policymakers, researchers together. And I think the other thing that the Alliance has also been very capable on is at the global level is working with partners and advocating for this field and how it can be taken forward, including investment. And we have seen over the last 20 years increased publication of health policy and systems research and increased investment in health policy and systems research. So in this new strategy, we're really thinking, why does the Alliance still exist after 25 years? And unsurprisingly, we've answered this with saying, yes, well, we should. There is a lot left to do. And so our vision is a world where health policy and systems research is generated and used to contribute to progress on health and health equity, including achieving major global health targets such as the SDGs. That is our vision. That it is in the end that health policy and systems research leads to health improvements, leads to improvements in health equity. Our mission, therefore, is to support the generation and use of high-quality health policy and systems research through building the capacity to do so in countries and supporting approaches to ensure that it's not just high-quality research, but that it actually makes a difference, that it actually has impact, that it actually realizes its vision. So that is very much our mission. It hasn't changed so much since what's described in our bylaws from 1999. But as you can see, there are some shifts. We are very much aiming for much more impact, building on the impact that we've already achieved as a community. In both our vision and our mission, we have core values. And here we've listed them. They are values of equity and social justice, gender equality, solidarity, and participation. Now, of course, it's easy to list your values in a document at the beginning. The question really is, and what you need to be held accountable for, is how are you implementing those values? What difference do those values make to the way you work? But I'm pleased to say that we have a community that takes these values very seriously. These aren't just the Alliance's values. These are the values of the health policy and systems research community, with a deep commitment to equity. And this is a community that is not afraid of holding each other to account and challenging each other to say, are you making a difference? Sometimes those discussions can be robust, but we don't shy away from those discussions. And I think we can, in the Alliance, point to concrete examples throughout our work where we've embodied those values, but we cannot be complacent. For example, with gender equality, Global Health 50/50 assessed us as a very high performer among global institutions, but we cannot rest on our laurels, and we have to continue thinking how we realize those values in practice, and we'll continue to do so and be continue to held to account by our community. So if that's our vision, mission, and values, what really are we saying in the strategy? What's different? And the main thing that's different is we say that we have 3 shifts. We've also decided to identify 5 priority topic areas, and there's a real reason for doing that. I think we just need to accept after 25 years that not everyone is going to understand what health policy and systems research is. It's a complex field, it's a multidisciplinary field, it's a nuanced field. But the reason we've identified these 5 topics is to show areas where we feel that health policy and system research in the Alliance can make a specific added contribution, but also that people who are working in these areas can see us as an institution and a community that can add value and be useful. And then we also have our 3 functions, which haven't changed so much, as I said, from the basic functions we've had throughout. So to talk a little bit more about the details of that 353, which is the framework for our new strategy. So first, the 3 shifts. And the one that's headlined in the title, we want to strengthen and scale up health impact. Our sense is that this, of course, has always been the intention of all health policy and systems research, but we haven't always got the co-creation right. Some of our embedded implementation research pays lip service to what we say are the principles of the field. And so the relationship between research and learning and impact isn't linear. It depends on policy cycles, budget cycles, it depends on luck, it depends on leadership. You cannot always tell what will be the unintended consequences of what you do. So whilst you can't guarantee impact from the work, whether that's improved policy, in improved service delivery, or improved health outcomes or reduced health inequities, what it is incumbent on all of us in this field is to create the conditions in a maximal way to increase the chances of our work having impact. Is it aligned to budget cycles? Is it aligned to policy cycles? Is it genuinely co-created? Is it serving a real policy question? Are we prioritizing journal publications over the way that people actually consume knowledge, whether they're communities, practitioners, or policymakers, and the intersection between those communities? And that's what we hope to do with that going forward. Secondly, we want to engage more comprehensively with country priorities and context. And I think this is something that all the science division led by Jeremy is hoping to do. Looking at the ecosystem, the interface between research and policy and practice. What, in terms of research, what features of research makes it more likely that it will enter the scientific advice to government and be acted upon? Who are the brokering institutions? Are we doing long-term engagement with particular institutions in countries? Because at the end of the day, we all know it's not people sitting in Geneva who make the difference. It is people in countries who know their systems, who have relationships. So are we ourselves doing the political economy analysis that we so espouse in our work for our own work and thinking about how we can engage with those ecosystems to make a difference? And then finally, building new partnerships within global health architecture. We're not a university. We're so privileged to be hosted within WHO and within the global health architecture. We've always had relationships with a number of other entities. For example, we have a long relationship with Gavi. So with this new partnership and strategy, we are thinking about other partnerships that we're building. And for example, we've increased our discussions with entities such as the World Bank and the Global Fund and others to see how we can make more of a difference, because we are sort of a relatively unique agency, however small we are, focusing on health policy and system research, and we believe it can add even more value and have more impact. So those are our 3 shifts. If we move to our 5 focus areas, and again, of course, we work on systems. We are systems people, so it's sometimes uncomfortable to separate out specific areas. But what we are responding here is, one, is to show that our scope of work has increased from some of the traditional work that's done mostly on the so-called building blocks of the health system, such as health financing, service delivery, or health workforce. But also, again, for people working in these areas, showing that the Alliance and the broader health policy and systems research community has something to contribute to their work and these emerging challenges. So our first priority area is universal health coverage through primary health care. That is our traditional area of work. It's still our biggest area of work. We have a long history in this period of work. We have a strong engagement with the health systems community, and we will keep doing that. Our second area of work is around digitalization. And here we work closely with Alain Lebrique and his team up the corridor from me now in the Digital Health and Innovation Department, thinking about how we can contribute on learning to ensure that digitalization actually improves health service delivery, it improves health equity, it doesn't create new inequities. That's very much the passion of Alain and his team, but we really feel that we can contribute something on research and learning. We've got some existing work around digital health for primary care managers, which we work with Alain and which Rajani and the team at the foundation is supporting us on. There's a lot more to do in that space, obviously. Thirdly, we are doing more work, and here we work closely with Rudiger and Health Promotion Department and Benter and the NCD Department on preventing premature death and disability from non-communicable diseases. So that's looking at both thinking about the role of the health system, but also thinking about multi-sectoral instruments. We do a lot of work already on health taxes, for example, that are required for primary prevention of non-communicable diseases. Non-communicable diseases are still often the big hole in universal health coverage. Fourthly, we are very much in a climate crisis, I think often recognized as the biggest public health threat of our times. And so really all systems, all public health needs to be responding to the climate crisis. And so we're thinking around how health policy and systems research can be contributing to building the resilience of health systems to react to extreme weather events, the increased systemic risks of various diseases, thinking about their own contribution to mitigating climate change, but also the role of the health system and other systems to make the case for sort of multi-sectoral interventions on mitigating climate change and reducing emissions. And then finally, but last but certainly not least, thinking about how to take a systems approach to health emergency preparedness and response. And given what we've lived through in the last few years, I think we all know the importance of a primary healthcare approach, the importance of systems, the importance of ensuring the connections between the clinical epi functions and the clinical services functions in our health system, the links between the health sector and other sectors. It's very clear that emergency preparedness and response cannot only be done by the health sector. I think we all know that. We've got a really clear illustration. We think the sort of work that we in our community do can be very helpful here. It's not just pandemics and infectious diseases. Unfortunately, we live in a world which is very clear with more and more conflict. If you look at the Uppsala Index, there are more and more conflicts over the last decade. We can see the impacts of that every day, so tragically. And so really thinking about how our field can also contribute to service delivery and other the delivery of essential public health functions in conflict and humanitarian settings. So those are our 5 focus areas. And then our 3 functions, really, these haven't changed. We essentially support the generation of new knowledge, the use of knowledge, the strengthening of institutions, and the advocating at the global level for investment and for thinking about how health policy and systems research can be useful. And so those functions haven't changed so much, as I said, since for 25 years. But thinking about our strategic shifts, thinking about our focus areas, we need to potentially deliver these functions in a different way. So quite a lot to do, as I said, and as Jeremy and Helen have reminded me, it's easy relatively to develop a new strategy, and we're very grateful for everyone's support. But harder to say, well, in 5 years, can we show greater impact beyond what we've already done? Just to close, to say, and I encourage you to read the strategy, of course, and let us know any questions. But here are some examples of our current work, and this is examples of our mostly new work, showing that the strategy isn't just some abstract thing. It also already reflects the direction that we're heading. And so last week, with our colleagues in the Immunization, Vaccination and Biologicals Department at WHO, we had a meeting to launch a new program of work supported by the Department of Health and Social Care on vaccine uptake and taking a systems approach to vaccine uptake in an era of new vaccines, unheralded, unprecedented new vaccines, for example, from malaria and TB, in an era of more vaccination across the life course, whether that's for HPV or COVID, in an era of disinformation, of real challenges in countries of all income levels. We do think that health policy and systems research can add something. As I said, we have a long now period of program of work on health taxes, thinking about the framing of health taxes, thinking about why we know the evidence that health taxes can make a difference. They can reduce the consumption of unhealthy substances. They can generate revenue that can be used usefully for health and social ends. And yet there's still real struggles. There's political interests that weigh against their implementation. So we've done work in a number of countries looking at that problem, supporting the colleagues in health promotion, thinking about how we can overcome the obstacles to the implementation of health taxes. We're very proud and grateful to be launching a new program of work around the governance of national public health agencies with the Berlin hub on looking at pandemic and epidemic intelligence of WHO in Berlin, Germany. And we will have a meeting in Singapore with 13 countries in the African CDC for a 2-year effort to bring people together to document governance and think about what works and doesn't work, as many countries are reconsidering the governance and how they institutionalize and deliver those essential public health functions. And finally, to highlight, with the WHO Health Emergencies program and also with regional office counterparts and country counterparts, we're launching a program of work looking at service delivery in humanitarian settings, looking at what have we learned thinking about governance issues, jurisdictional issues, the sort of reconfiguration of workforce. And there's already quite a lot of knowledge on this, but we think that the work we're hoping to do can add something. So that's very exciting. So we do have a new strategy. We are grateful for all who've contributed to it. We're grateful for all our partners on the board, on our scientific, technical and advisory committee. We're very grateful to all our funders. But we really look forward to all of you engaging on this and contributing, and including our colleagues in Science Division at WHO and all of our partners. So with that, as I said, you're very welcome to ask questions in the Q&A, but we will now move to the panel discussion, which we hope is complementary to what I've just discussed, looking at our strategy, where we have 3 wonderful people who have sort of a lifetimes of experience around the use of health policy and systems research to move forward challenges in their own countries. And we're going to discuss a little bit about those experiences and how we can do better. But please do raise any questions you have in the chat. And when we get to the Q&A, we can take those. So welcome, Rajani, Keith, and Diah again. So as I said, Rajani Ved is the Director of Health at the Bill and Melinda Gates Foundation in India, which she's been doing for the last few years. But before that, Rajani is in the trenches practitioner, researcher, a real passion for the community level. And I first met Rajani when I was working at UNICEF. She is one of the people who really contributed to the ASHA program in India and many other achievements. And she has very little tolerance for research that doesn't actually serve people's needs. And so we're very grateful for you to joining us, Rajani. Keith Cloete, as I said, is the head of the Western Cape Department of Health and Wellness in South Africa. It's interesting in South Africa that they've now added wellness. Often it's departments of health. It's now the Department of Health and Wellness, which reflects a strategic shift. Keith has 30 years as a health policymaker, practitioner for that, working in the health sector in South Africa, starting during the time of liberation in the 90s in South Africa. Keith is well known to us, and he's someone who is very practical. I remember last year I had the privilege of visiting Keith and visiting a primary care centre in Mitchell Plains. One of the things I was really impressed was 2 things. One is that even though Keith is the head honcho there, they still searched our car. And the second was to see these very energetic leaders, nurses and doctors who were ruthlessly interrogating Keith about some of the strategy and some of the challenges they're having. So I know Keith is someone who really values learning and is someone who has really integrated that into the way he sets his strategy, his practice, and his implementation. And then we also have Diah Saminarsih, who also is someone we know well. So Diah is currently the founder and the CEO of cisdi, in Indonesia, which is a civil society organization, which has recently launched a very interesting white paper on primary healthcare reform in Indonesia and held a very successful convening aiming to influence primary healthcare in Indonesia. But before that, Diah has done multiple things. She was a director here with a real passion, particularly around youth and gender, here at WHO for many years, advising Dr. Tedros. Before that, she was an advisor to the president of Indonesia during Indonesia's engagement on the development of the SDGs. So she's also someone who knows very well about the interface between evidence and policy and practice. So what we're going to do today is Keith, Diah, and Rajani have very kindly indulged me and said I can ask them whatever I like. But we're really going to think about, well, what are these experiences with our health policy and systems research makes a difference? And what we'll do is I'll ask them a couple of questions, then I'll ask some follow-up questions. We have almost an hour. And then, as I said, we'll be able to take some questions in the Q&A. So please post your questions there and we'll monitor them and then feed them to our very esteemed panelists. So the first question I'm going to ask to all three of you, just to set the scene, maybe to give us some examples. And I suppose as the Alliance, we're interested in your country work, in your countries that you've worked for so long. How do you feel that health policy and systems research has assisted your work? What has been the positive of the field? And are there examples you can give us where you feel that you can point to, and just one or two, where research and learning has really supported policy and implementation, actually changed something in terms of service delivery and health outcomes? And if you don't mind, I'll start with you, Rajani. So over to you.
Thank you, Kumanan, and thank you for having me on the panel. So I'd like to reflect back on a couple of areas where health policy and systems research helped us. And just to put this in context, in 2005, India launched a huge health systems reform initiative called the National Health Mission. And in the design phase, this entailed a huge paradigm shift from everything that health systems were doing at that time. And there were multiple new interventions addressing a complex set of interventions, really addressing several wicked problems. But in particular, I'd like to allude to two programs. One was the ASHA program, which is India's community health worker program. We have 1 million community health workers. And this was about 5 years after implementation. The design of the program itself was contested. Multiple stakeholders had views of the community health workers. Some viewed them as activists, some viewed them as service providers, and some viewed them as just link workers to link communities to the health system. And as a team that was in charge of this program, providing technical assistance really to multiple states in India for this program, we embarked on an evaluation combining both quantitative surveys as well as qualitative interviews and used the realist methodology. And I think the findings of the evaluation done in multiple states using a systems lens yielded information that actually changed the profile of the ASHA and enabled high-level investments, multiple investments into the training, support, supervision, which we all know are very important for community health workers. A community health worker does not stand on her own. They need an ecosystem of support, training, supervision, constant training, that is, a drug kit, modules, all of this. And this evaluation results in 2010 changed the program to convert her into getting skills. And so adding skills to the ASHA, and it was a difficult process. We had to transact the results of the evaluation with practitioners, with policy makers, and enable them to see that this was a huge missed opportunity. We had 1 million workers who were not actually supporting the program, but were just serving as link workers. So it's a long story, but this is a story that I think has achieved immense change in policy and implementation and actually set the way for, I guess, in COVID times, what the ASHA proved themselves to be as the bedrock of the system. And without the ASHA, I don't think India could have had the kind of response to COVID that we did. I have another example, but I'll stop here now and ask you to allow it. Thank you.
Well, thanks, Rajani, and I mentioned that also in my introduction of you. I mean, the National Health Mission, the ASHAs, was something that was a sea change, and I remember in the 2000s. And what you've just said is the use of health policy and systems research to guide the development of the program, then continuing through to monitor what's happening in evaluation, and then acting on the learning to then iterate and course correct and change the program. So that is all the principles we say should happen. So it's nice to hear that it did, and I know that, and obviously going back also from the Mitten program before. But of course, to do that at scale in India is so challenging. Right? And I think one other thing that has been very pleasing to see over the last 20 years is the growth of the field of health policy and systems research in India. And so we have people, not just you, but you have a whole cohort now of global leaders in health policy and systems research and institutions. And so, but I think that wouldn't have been possible if you hadn't demonstrated the value of that sort of work by, what you've said with the ASHA program. We'll come back to you on your other example, but before we do that, let's go to Keith now. And I've seen how you engage with health policy and systems researchers in the Western Cape. But for our audience, could you perhaps sort of give your perspective on how it's been helpful for you and give some examples where health policy and systems research has actually made a difference to the way you deliver services and to health outcomes?
Thank you so much, Kumaran. I think the big advantage we have had is we created a community of practice that broke down the walls between policymakers, researchers, and implementers. And actually, it's in the form of a journal club. So we met one another once every 2 months, and that journal club has been going now, it's going into its 12th year. And it became a safe space where, as health systems researchers, policymakers, and implementers, we started developing similar language, similar approaches, similar ways of seeing the world and sense making. And in a sense, what that led to is it influenced the thinking in our department. So we were in a position to co-create, to commission, to work with the researchers. And actually, researchers played quite important roles in our system. They become soundboards, they become facilitators, they become part of our strategy think tanks. So it's become an integrated way of looking at the world, at the systems from a system perspective. And that gave rise to quite a few things over the years, over the last 12 years. Some of it worked at a very, let's call it street level bureaucrat work, understanding what happens at the interface with the client and as they come into the system. Some at district level or sub-district level, that is decentralized leadership work about decentralized capacitation of systems, but some at whole system level. And I guess the value for us is that we've done work at all three of those. We've done local, let's call it provider interfaces. We've done district coordinating and empowering decentralized decision-making spaces. But the whole system review was a fantastic thing for us. In 2016, there was a whole system review that was done by a combination of researchers plus our own staff plus policymakers. And we look back over a 26-year period of why things in the Western Cape work with a whole system lens. That set up a whole thing for us where we are now. We got into COVID, we did fantastic, real research. We have a data center, we have generation, and we have embedded research as part of our architecture in our department now. And the resilience work helped us, the emergency preparation work during COVID, all of that came together in a systems lens. At the point now where we are let's call it a primed system, because we have whole system appetite. We engage everybody, and our big interest now is to do quite a big, rigorous retrospective review with a prospective understanding of systems evolution and emergence as it happens, and evaluating it, and building in the process HPRS capacity that's distributed between ourselves and our research partners. There's two practical examples that I would like to quote just for you. The one is, because of this culture and nature, we have very, very clear relationships with universities locally. And because the universities and us work in a co-creative way, we have embedded researchers in our system. So during COVID, we did a whole lot of research on the basis of the emerging data. And we did implementation research, impact research all the time. And the second one is we've been actually very instrumental in developing something which is called PAC guidelines, which is now gone across the world, actually in multiple countries, as primary care guidelines, which is evidence-informed primary care guidelines. But those are two small practical examples. Thank you.
Yeah, thanks so much, Keith. I mean, that sort of, we talk a lot about breaking down the silos, but it is quite challenging to change the culture. I mean, researchers are often in academic institutions. The incentives are quite different to the incentives and the interests of practitioners, of implementers, and then of the policymakers. So it's interesting that you've used a journal club, I think, to do that. I mean, and that has been the way, one of the ways you've done it. And then I think the way you've done primary care. I mean, it was very interesting to see all the innovations you were able to pilot and trial and scale during COVID. You used the crisis in a very innovative way, and I think COVID was an experience that we had, anybody, including myself, was part of a COVID response in a country where you couldn't wait for papers necessarily. I mean, there were some useful papers that were produced quite quickly, but you had to share knowledge in different ways, in creative ways, try new things, see if they were learned. And so we should really apply a lot of that type of thinking more generally, right? There are a lot of lessons there about how we can have more impact. So just for this introductory round, Diah, if we can move now to you, and it's the same question. Where has health policy and systems research been useful to you? And maybe one or two examples specifically where you think it's had an impact.
Thank you, Kumanan. Good morning, good afternoon, and good evening, everyone. So in our work, as a civil society organization, when cisdi was first set up 10 years ago, our approach has always been through health system strengthening. So looking at the health in a systems perspective as opposed to disease perspective. Back then in Indonesia 10 years ago, that is not a common way of approaching health, not by system, not by disease. So I think right now, Indonesia has made a lot of progress in looking at health not as a list of diseases, but as a system that if that system is reformed and done well, governed well, then disease elimination will fall into its targeted numbers. I think if I may start from the challenge, the main challenge that we face in our work is how to support, provide a policy recommendation and support our policymakers in providing the correct translation of science or research into not only to ensure policy is made in the right way, but also giving it beyond numbers, but more as practices and as impacts. I think sometimes we have to acknowledge that policymakers do not have the luxury of time, and it is always better if we can package the numbers of the research or the results of the research, the findings, the study findings into practice. What has been done, what hasn't been done. I think that is where the strength and convening power of the Alliance will support our work better. As a reflection and the lack of this translating capacity, Indonesia has started Puskesmas or our public health centers long before. There is even a talk about Alma-Ata long before that. But the lack of evidence and scientific research in primary healthcare and the lack of practices that can be presented as something to copy, something to be adjusted in practice in Indonesia, I think is one of the cause of why primary healthcare in Indonesia is lagging behind. Right now, we are catching up on that ever since back in 2018 when we renewed the Alma-Ata Declaration and then there is that operational framework of primary healthcare and the uptake of the current administration of the need for reform in primary healthcare. I think we are in a good dynamics for full-fledged reform of primary healthcare, but it can be strengthened by more research, more findings, more best practices, in which I think an alliance of and research on health system will be I think super important into the strengthening the current uptake that the government is already taking on primary healthcare reform. As a reflection, building on Rajani's point before on ASHA, now cisdi is embarking on a new set of additional variable into the ecosystem framework, which is community health workers. So if there is an uptake of the evidence already found and in ASHA into something that what can be translated quickly into policy for community health workers in Indonesia, I think that can make reform happen quicker. And the last point is that our white paper that you mentioned underline this key importance of approaching health as a system and reform and looking at primary healthcare as an ecosystem instead of just part of the health system itself. So I think this is a very good time for your strategy to be launched, and thank you for the work in the strategy. And also we look forward to utilize the strategy and embed that into our work in Indonesia. Thank you.
Thanks so much, dear. And as you, it's interesting to reflect. I mean, even Indonesia now has a range of strong institutions, including yourselves, that can use evidence to inform practice and policy. And yet it's a very big challenge in your subcontinent, like in so many islands. And the challenge of primary healthcare after over half a century remains. But I think your point, I mean, one of the strengths of the field is the ability to share experiences. And on the one hand, we say we need contextualized knowledge, which is specific to a country or the subnational level. But on the other hand, it's this ability for people to share experiences against countries, perhaps at different trajectories or different stages, to say, well, we had that problem before, this is how we handle it, this is the sort of evidence that was useful. And I think that is something that the Alliance has always envisaged to do, and something that we will do a lot more of. I'm going to turn back to Rajani. Viewers, the audience will notice that Rajani is now in a car. Whenever you talk to anyone in India, because they're so busy, because it does have, you know, the world's most populous country, they're always doing a million things. So the number of calls I have with people in taxis or at airports, I think you and Samia are the champions of that, Rajani. But if you can still hear us and you can still speak, that shows your commitment. Perhaps reflect again, you set a very good example with the National Health Mission, but what are some of the challenges you've seen in your career where research and evidence has been generated and it hasn't had an impact? And what are some of those challenges? And maybe what are some of your suggestions on how we can overcome some of those challenges? So if you are able to still speak, back to you, Rajani.
Thank you, and my apologies, speaking from a moving car, but there's technology for you. So that's one of the good things. You know, I think some of the challenges, and if I may, I'd like to speak about some of the important lessons that came to us because they were challenges and they were really lessons learned.
Absolutely.
And I've been part of other research before, but I think what distinguished the example that I gave was this dissemination of findings and building them into research is just not moving towards impact, if you will. So we had multiple consultations with the practitioners and policymakers to make sure that multiple facets of our learning were incorporated back. And I think the counterfactual of that is the kind of challenge where you don't do that, where you do the research, it leads to a little bit of change. But I think the multiplicity of the outcome, if you will, is much more heightened when you continue to do this as a process. And the hand-holding of implementation is another very important yield from health policy and systems research, because it informs multiple stages of the policy cycle. It's not just the development of policy, it's the implementation. It's the continuous evaluation of the policy, because I think the policy, as the program unfolds, it undergoes changes in the field that you don't really anticipate. And even the best of designers, people who have the experience, who understand nuance, and things happen in the field. You have new emerging challenges that come up, and unless implementation takes that into account, and you're constantly looking at it, it just ends. And that's why it has to be so important that health policy and systems research has to be conducted by an embedded organization. And I don't mean to be monopolistic about this. Embeddedness is critical because they get the nuance, they get the understanding of the entire picture rather than having an outside agency come and do it. And having said that, I think the challenge is that we don't have sufficient embedded skills. And I think that's been a huge challenge. Having multidisciplinary skills come to health systems and policy research, and even though this is an ongoing process, there are great interventions. The foundation itself funds and building capacity and the numbers of health policy and systems researchers. But I still feel the skill mix is not sufficient to get the potential of HPSR as it should. So that's a challenge. I think the second challenge I'd say is multi-sectoral interventions. I'm not sure that we've come to this understanding of what are the different methods that are needed in order to evaluate and then, of course, modify multi-sectoral. It is a big problem. Multi-sectorality, we all speak about it, but how do you make it real? How do you get it introduced into programs? That's a challenge that I think collectively we have to work towards. I think another challenge that I say is we need the findings of research have to be presented to policymakers. First of all, timing. Nobody has patience. I think somebody else mentioned that. It's got to be at the time when they need it most, around budget cycles, as they are planning for the next year. Bringing these research findings and drawing to their attention the diversity of context and the importance of strengthening local challenges that I don't think we're moving to. And my final challenge, I would say, is how do you structure the research or design the research that you're looking to inform scale? Because small projects, relatively simple, but when you go to scale, particularly I'm talking India, notwithstanding diversity, there are still common challenges. But how do you address research? How do you design the research to be able to demonstrate scale? I think that's the third challenge that third or fourth. So I'll stop here now, Kumanan. And
thanks so much, Rajani. You did cut out a little bit, so I'll just summarize for the audience. But I think those are those key challenges. The first point of embeddedness. Now, we often tie ourselves in knots trying to define what embeddedness is, and this phrase embedded implementation research is quite inscrutable to most people, a bit opaque. But this idea that research is actually taking place in real systems, in real organizations, meeting real questions, and that it's not an external thing. That is the equality we aim for. And you sort of said, really, it's almost essential. And that means that the work it's about the relationship. It's not a one and done thing that, we talked across the different groups, but it's actually iterative. And that at all cycles of the implementation cycle, the policy cycle, you're having this relationship. And that's why the relationship of institutions who do this sort of work is very important. And I think that's something we've struggled at. I mean, too often we see sort of implementation research, they're wanting to do dissemination workshops at the end. And this is a contradiction. I mean, if you're doing it embedded, you don't need the dissemination workshop at the end. You might want to share your experiences more broadly, but it should be immediately of interest. But as you say, the challenges of doing that. I think, the other challenges you pointed about of scale is very important. It's often our field is still too projectized, and it's great if you can inform a project, but what does it mean for the system? If we are really serious about doing systems work, it should work at scale. And then your point about, well, people are too busy because they have to get in taxis, that they don't have time to sit in webinars, they don't have time to read papers. So how are you sharing information, and how can we be more creative about that? And I think, these are features we've struggled with for a long time, but I think, as you say, it's very, very pertinent for you to highlight these again, because they remain key challenges if we're serious about having more impact. So back to you, Keith. Again, I mean, you don't have a problem with embeddedness because you're the head of the Western Cape Health Department. But what are some of the challenges, or what are some of the frustrations you've had? You painted this very beautiful picture that you've been able to break down the silos, but what are some of the frustrations, challenges you've had in terms of health policy and systems research? And again, maybe for you to reflect on how to overcome those challenges. And you're on mute, Keith, so I think you'll need to take yourself off mute, please. Thank you.
Sorry about that. Thanks, Kumanan. I've got 4 challenges, and I will also explain how we've turned the challenge into a positive for ourselves. So let me start with the first one, and this is in the national context. So as the head of the provincial department, I'm part of the national body that looks after policy for the country. So one of the key challenges is what I would call competing policy influences. Because the point is, HPSR is one source of evidence, right? But it competes with data, with opinion, with perspectives, especially strong political influences when it comes to health system development, as opposed to possibly clinical guideline development where evidence is more kind of accepted. The point is, HPSR is competing with other forces to influence the policy agenda. I've seen that firsthand. Now, obviously, I've explained our context where we've made HPSR is quite central to our thinking, and we've all went to whole system. Therefore, for us, it's important to actually engage others from that perspective. But in other contexts, it is still a competing field getting to the table and influencing paradigms and influences when people make those decisions. A second factor, and obviously for me, overcoming it, is making a systems approach central to it. Influencing the ecosystem to think that way. That's the way you overcome it. The second one is a very strong compliance culture in a health system. And that for me is signified by this very entrenched log frame M&E systems that comes from very strong and powerful global entities as well, and funding agencies. And for me, it stifles the approach, any approaches to learning culture. So again, the way to overcome that, we went for intentionally going systems approaches. Actually, in our organizational design of our organization, we do not have program coordinators anymore. We only have system enablers. So we have overcome the fragmentation that comes with programmatic priorities that is then entrenched with log frame indicator tracking. We've overcome that, but that is quite a powerful one. The third one is political and governance context. So, and at the country level, you can understand that these are quite contested, the politics and the influence. One of the whole system review positives we had in our province is there's a very healthy separation between the administration and the politicians. And in a sense, we as administrators can then set long-term policy continuity and health system, health outcomes, and also going into what we would call social determinants work. And because we are doing that as officials, it is not bound by 5-year political terms. And we're not into the short-termism way of view, because it's very important for us. That's why actually our whole of society interventions in COVID took a complete acceleration, because we were actually called as the healthcare system as a steward into the center of whole of government, whole of society. It really catapulted our ability to do that. And the last one, I guess, is what you just said, Kumanan, you witnessed it when you came to visit us, is crisis mode. We are fortunate, we overcame the crisis mode because we have wired our system with capability. So my time is not taken up from running from one crisis to the other. I'm obviously a little bit fortunate that I can work in a system that I'm not, running from here to there and not have enough time to actually spend some time on that. But I believe crisis mode takes people back into silos. crisis mode take people into survival just from here to next week. And what you need for a systems approach and a policy approach is a little bit more long-term, proactive, longer view. And for people to get out of crisis mode, to go more into abundance mindset, to say, look, we can share, we can do this, we can build bridges, break down the silos. Crisis mode is a very, very powerful impetus for policymakers to keep them away from this work. Thank you.
Thanks so much, Keith. I think those are all very key challenges, and also your experiences of how to overcome them are very helpful in someone who's actually doing it. Your point about how policy and system research is just one mode of knowledge, which is competing. There's a marketplace of knowledge, and that we just need to engage with that rather than being frustrated about that, I think is very important. And that, you know, I think sometimes there's a perspective in public health, a technocratic perspective, that we have this knowledge, we have evidence, why aren't people doing that? And I think COVID should surely have challenged us to think about, well, what motivates people's behaviors, both at an individual level, at a population level, community level, and just to be humble about what is our contribution. But then embrace with that and think, well, where is health policy research useful? Where is it less useful? And not think we have all the answers. I think that's very important. Rajani also made the point about multisectorality, and that we should be humble about that. And that, I mean, as some of you know, I've worked on social determinants for a while, and we are still guilty of spending a lot of time as health sector people talking about what the other sectors should do, and then wondering why they're not doing it. We have very sophisticated theories and analysis about what's going wrong. And we're also not very good, often at engaging where other sectors are further ahead than us. They have their own system science, they have their own measures, they have their own interests. So again, if we want to address these complex multi-sectoral challenges, we need to work better on that. And your point about crisis mode is an interesting one. I mean, there's often a romantic sort of interpretation of crises that that's when you can really change everything. And that's true to an extent, but it depends on as I think, as you and I have been discussing on some of the work we were doing on the framing of crises. And if part of the reason for the crisis is seen to be the segmentation and the fragmentation, then you might be able to do something about it. But as you say, the other thing that often happens is that people retreat into their camps, defend their territory, and don't want. It is interesting to see how you've integrated health policy system research throughout your work and your organization, and it's very much embedded. So then we'll move to you, Diah, you've already reflected a bit on the challenges, but if you have one or two additional points on the challenges, and then we'll move to some of the Q&A questions. So over to you, Diah.
Thank you, Kumanan. Yes, I think fragmentation is an issue. Sometimes people, I will refrain from saying policymakers only, but all the actors involved in a sector rarely talk to development actors in another sector. And that becomes a major challenge when we try to see what evidence are there, what practices are out there that will be beneficial for our sector, because we simply do not communicate with people beyond, because all of us are in the health sector, beyond the health sector. I think that barrier needs to be broken down if we want to really utilize the wealth of evidence and research and utilize it to strengthen and reform health system and health policy. Also, I think we sometimes overlook, Keith already mentioned about the competing influence from global to national, but also the competing priorities at national level and even at subnational level, due to various reasons, most probably, or what happened often is because of political preference, political outlook, and then all of a sudden a certain direction changes and priority changes. I think it's always a fight within the health sector itself. Which area is it? Should we invest in health system or should we invest in something else? should we invest in research, or we go directly into communities and do a pilot without having the research? I think those competing priorities are unique to each country. Some are more influenced by political agenda and political direction. Others are less so. But it's our hope that with our for health, that influence be made to a minimum, and influence of evidence and scientific evidence and best practices are valued more than political influence. I think that will help significantly, where we can set health development agenda on a long-term progress, not 5 years, but not every 5 years, but perhaps 10 to 20 years. It points into a main direction that everyone agrees on. So I think that's more or less a challenge. And if the Alliance can provide examples, scientific evidence, and research findings for that, I think it will be super helpful, extremely helpful for policymakers and other actors to set a constant direction or guidance for a longer period of time. Thank you.
Great, thanks so much, Diah. And I think those those are not easy things to do, but are important points. So if my panel doesn't mind, we might move to some of the Q&A, and we've got a great set of questions from a great set of people in the Q&A. Some of these questions we might have to get back to the questioners afterwards with the materials, because the answer will be quite long. But some I think we can answer. I think there's a set of questions here from Lubna, also from Daniela, and also from Karen, about, well, this takes many different partners and institutions, right? And a reflection on how some of the discussions here at the national level, but how do you replicate this culture at the subnational level, at the provincial level, the community level? You all have experience of that. That's one question. Another question is, well, how do we bridge this gap between academia and policymakers? I think you've already answered some of those questions. There's a question from Karen about the role of schools of public health. Keith, you might be well placed to answer that, given you have a very sort of close engagement. Nina asks, and thank you, Nina, to you and your team for your help with our strategy at Spark Street. Nina asks, well, you've painted the positive. Would any of you like to highlight an example where there was good evidence to change policy and you couldn't change the policy for other reasons, right? So maybe we'll start with and then Joran, who is really one of the fathers of the Alliance. Joran Thompson is online. Hello, Joran. It's great to have you with us. And he asks, well, new partnerships for the Alliance and strengthening institutions. And given the fragmentation and the landscape we have, the many players, both globally and nationally, given all the crises we have, the geopolitical things, well, how do you strengthen institutions? Which partnerships should the Alliance be engaging in? Should brokering institutions and countries be engaging? So that's a lot. Maybe I'll just help you a little bit. Firstly, Keith, do you want to speak a bit more about how you're a provincial, right? You have a link to the government at the national level, but you turn up at Mitchell Plains and people interrogate you and ask you, well, why are we doing this, right? So maybe a little bit more on how you've got it at all levels, system-wide and system deep, as you say, right, Keith? And then maybe also a little bit about the relationship you have with the schools of public health.
Thank you very much, Kuman, and really excellent questions. So maybe just to preface what I'm about to say, to how we got to the system-wide, system deep. And one of the persons asked, how long does it take to get a culture of wiring systems thinking into the way you do it? I think one of the beauty for us was when we did do health policy and systems research, we actually did it at the same time at multiple levels. So we learned about frontline staff realities. We learned about coordinating at district level, and we learned about what the intractable nature of a whole system would be. And we learned about whole system, not just internal health, but with external parties as well. So we actually had system learning at multiple levels at the same time. And the interesting thing about, when you asked me about the journal club, the interesting thing about the journal club was all of those were pulled into the same pot at the same time. So we would have contested and quite robust conversations about how a frontline provider sees the world in relation to a researcher, how a district person sees the world in relation to research and academia and to head office, and how the whole system sees it in relation to universities and all of those. So there were two key important things that happened to us that helped us with this. We became very intentional about an organizational culture of moving towards participatory, leadership-led, and an open culture of transparency and giving people voice. It was very important for us in hindsight to actually give people voice and to look at the historical and the, let's call it, the power-based stuff. Before we even had the language in the systems, we went into the public. That's why you saw what you saw. Is I don't stand on the tension of a title. I don't stand on the tension that because I have positional power, I control things. I leverage of interpersonal power. And people know me and I'm approachable, and that's the way we do it. And I set the tone with that, but everybody else does it in the same way. So it's quite important that you do that internally, but then also with external parties. A critical decision that we took, and our colleagues I met with colleagues this morning, they went to Brazil to look at their data center in Brazil. And the interesting thing that they came back with is we took a decision very, very early on as a strategy at the center to make public health a central piece in our department. So we deliberately went to the universities, the units of public health, and went to them to say, let's make your staff, joint staff with us, but they have a specific role to play in the department. And we created a location for public health specialists in our department. So much so that the public health specialists in our system firstly see themselves as being part of the health system before they see themselves belonging to a university. So we embedded public health into our system. And it's a very, very important thing because we did that some 15 years ago. So it set the tone for doing this. And this is the last point, Kumanan. I think I'm very intrigued by this notion that you and Diah introduced of thinking of an ecosystem, because we found the language now. But it was very important for us to think in the systems thinking, that we are an ecosystem for a healthcare system. But I'm now more and more saying, after COVID, I'm locating myself as the head of department with my other fellow heads of department of other departments, and with municipalities and national entities outside sectors. I'm now positioning myself as, because of the stewardship role, I am part of a well-being society ecosystem. So it's beyond the healthcare system. So the moment you start doing that, it opened all kinds of doors, because we're talking about economic and social development and the well-being of people in households and poverty and inequality and all of those things. And I'm not doing it from a health perspective. I'm doing it from a societal perspective. And that has also helped. And there was one other colleague that asked a question about very context specific to the Western Cape. But I think to the South Africa. The reality is one of the biggest things we've done is we've taken, because the systems lens allowed us one thing, is to be open to different perspectives. And because we're open to different perspectives, we do not create binaries. We do not create opposition. So in our system, it's not a language, it's highly specialized services versus primary care. It is rural versus metro. It is the private sector versus the public sector. And therefore, because of that, we are working in partnership with everyone. And therefore, we have been able to depoliticize, de-escalate, actually, contestation and conflict. Not altogether, it's the manner in which we show up. So in our own context, there's a very politicized thing, which is the NHI introducing UHC. And there's lots of polls. Our position is we work with everyone to find practical, workable solution to bring UHC to be in our context. Thank you.
Great, thanks, Keith. I think it is that sort of humility and thinking about valuing different perspectives, and we talk a lot about that, but how do we put that into practice? You're also fortunate in terms of your relationship with public health schools to have some of the finest public health schools on the planet to do health policy and system research, and giants like the Lucy Gilson, Howard Schneider, and you have ASHA George, many others. So, but you have made that space, and I think that is kind of, I think, a very good answer to many people. Rajani, for your sort of final intervention, maybe we could ask you a couple of things. One is this challenge of institutional building in countries. How do we do that with some of the challenges of fragmentation? How do external partners help, given that you have two hats? You have an external hat now, but all your life you've had the country hat, the institution. And then there's also a question about the role of the private sector. So maybe you'd like to speak to that, about the role of partnership and how together we can support building institutional capacities in challenging times.
Thanks, Kumanan. On the institutional capacities, I think it requires not just financing, but also financing is very critical. Financing, creating the mandate, the norms and the rules around which institutions are to be set up. So there's not duplication, but there is a single separate function that multiple institutions can provide. So thinking through this whole framework is important before you start to actually either create new institutions or change norms around institutions. When NHSRC was set up, we were a new institution. So there was a luxury of having a new mandate, entering the health system space, which no other institution had done. But sometimes it's not that easy. You work with existing institutions, you identify the gap that exists and what changes can be made within existing institutions to meet that gap, create the HR and the personnel that are needed, and assure them of constant financing. I think the tension here is when you underfinance institutions, then faculty and personnel are actually spending all their time raising resources and not devoting as much time to either skill building or strengthening the system that is required. So I think it has to be a well thought out function. And in fact, the more local you get, the harder it is actually. We also can look at community-based organizations, which I think we don't tap into enough simply because they're too tiny. But a network of community-based organizations can also yield us useful partners in engaging for health policy and systems research. So I think that's an area that needs more thinking through, particularly in India, as we have changes in our foreign country license applications, then we will need to turn to domestic partners and creating networks that could support this. So institutional networks are also an important function. Your second question was about private sector. I'm not sure the context. I didn't look at the question exactly, but I think in addition to, it's easy to say involve the private sector, let's have them as partners. But unless there's a regulatory framework in country, engaging with private sectors on particular functions, particularly for service delivery, is a bit fraught, I think. And so private sector partnerships, again, another area where we have to look to globally to see where they worked, on what areas can the private sector actually partner, or should health facilities be handed over to the private sector? Can medical colleges be handed over to the private sector? And I don't think there is sufficient research, at least in the Indian context. We don't have enough research on what private sector partnerships have been successful, under what circumstances. And this broad thing about engage with private sectors is actually a bit frightening, if you will, because they come in different shapes. So I'll stop there now, but I can answer another question if you want me to. I can go back and look at the private sector question. I didn't actually look at it.
Great. No.
I'd like to take one. Hey, Kumanan, I'd like to take, if I may, just in 2 minutes, Diah, I know I'm eating up your time a little bit. The question on the failure, how acting on something and then it didn't get converted into policy. And so in about 2017-18, when the primary healthcare reform was being launched in India, we knew that adding additional packages to primary healthcare like NCDs and mental health and palliative care would require an additional frontline worker. And and it was, the evidence was there in the field, the overworked ASHAs, people, because she had built up so much social capital, people were turning to the ASHA for almost everything. The system was heaping things on her. We made a strong pitch for a second community health worker and did not succeed. So despite having the evidence that having a second community health worker would actually enable the primary healthcare project reforms to become operational, we didn't quite succeed in that. Over.
Thanks, Rajani. So we have just a couple of minutes left, but I'd like to give Diah one last chance before we close. So just 1 or 2 minutes, Diah, and maybe just reflecting on that. I mean, you're now back in civil society. You've been in government. You've been in WHO. Helen Schneider, who's the chair of our Scientific Ethics Revising Committee, asks, well, in a sense, you need policy stability to implement change and see the benefits of research and learning. And you reflected on the challenging trajectory around primary health care. We also just heard Rajani, that very honest thing of the challenge about when research doesn't immediately at least lead to the change that you have the evidence for. So do you want to give some final reflections on that, on the challenge of, there's a question also, well, how do we make policymakers value evidence more than political economy? I suspect it's not either or. So do you just want to give just maybe 1 minute, if you don't mind, just some final reflections on those sort of issues around how we support evidence and research to actually make a difference?
Yeah, I think one of the biggest challenges is how to break down frame of mind barriers that international organization must only work with government. It must only work with donor. Civil society is located on the other end of the room. I think that is the hardest challenge to overcome. What we're trying to do is to bring everyone together, make it a new normal, where like this webinar, everyone is together and we are discussing based from our own perspective. I think that remains the biggest challenge, how to, not so much as if civil society is on the table, but if we are even in the same room. So it's, I think, the willingness to do the role play, Kumanan, if you will, to wherever you are, just being inclusive to other development actors is really important, because there is something that you bound to miss. There is perspective, there is expertise, there is frame of thinking that surely you will miss if you are only thinking from your side of the room. And I think I would like to spend my last 30 seconds to answer Nina's question about whether lack of evidence fail us in a way. I think Indonesia just issued the new health bill. Cisdi was trying to convince to invest more into the health system, and to invest and include community health workers as part of being paid by merit, based by merit. We were not too successful in doing that. I think it's, as opposed to lack of evidence, I think it's lack of communicating the evidence that presents the problem. I think evidence is out there, but communicating it and getting it into the table and the minds of policymakers and parliament members as they draft the bill was a challenge to us. So getting everyone in the room, Kumanan, is, and for that, I thank you for getting everyone in the room today.
Well, thank you, Diah. Well, we are at an end. So firstly, I'd like to thank Keith, Rajani and Diah. We're so fortunate to be such an interesting conversation. We'll put this up online on our website if others want to hear. I'm sorry we didn't get to all the questions. The ones that we can easily answer, we'll also try and get in touch with you and give you the answer. It's been such a rich discussion. Thank you also to Helen and Jeremy. We're incredibly fortunate in our leadership. I think what we've heard is that not every health department is going to have a head like Keith, who's we've brainwashed about health policy and systems research, right? Not every funder necessarily has someone like Rajani, who is somebody who's been in the field, has used research, has done things at scale, and really understands the difference it can make. Not every civil society organization has someone like Diah to really steer them, who has the relationships, who understands how civil society can play a role. Not every organization has a former prime minister as the chair who spent her life trying to translate evidence into policy and practice. It makes a difference. Or a WHO representative who, as I said, is one of the world's greatest scientists. So we are very fortunate as a community. What I think we take from this, though, which this meeting reflects, as you say, Diah, is it is about bringing different perspectives. There's no monopoly on knowledge. We are an interdisciplinary field. We are a multi-sectoral field, but we really try to bring in this ecosystem the different perspectives and have a debate, and we all have something to contribute. Research is not the sole domain of academics sitting in a university, although they are very important. And communities, civil society organizations, practitioners, the private sector, everyone has something to contribute, and it's only by bringing people together that you solve and you can address the crises we have and the complex challenges we have. And that's the whole point of health policy and systems research. But it has to make a difference. The time to be content with conceptual frameworks, at least for the Alliance, is over. And as we now move forward into our second 25 years, that's the aspiration of the strategy, which is to have more impact. Not everything we do will have impact. There will be the examples like Rajani and Diah said, where we fail. But we must create the conditions in a system, take a systems view to our own work, be humble, bring people together. And so thank you to all of you. Thank you to my team, to our staff, to our board, all of our partners, and our community, Health Systems Global. I mean, it's an amazing community to work in. So it's been wonderful to spend the last hour and a half with you. But we hope you'll continue, as Helen said, to really contribute to us, to critique us, to challenge us, and work together, not just to aim for impact, but to deliver more impact. So lots more to come. Thank you again, and have a good rest of the day. Bye-bye.